Hello everyone, my name is Shivam Dhiman and I'm a second year student from Western Sydney University. I'm supposed to present a topic which is COPD. There is a case study given along with some clinical manifestation. Just before relating the clinical manifestation along with the case study, it's important to know about the disease first, and then we can easily correlate with the clinical manifestation. So, what is COPD? I'll just share my screen with you. And yep, there we go. All right, so let's talk about COPD first. Okay, so COPD or chronic obstructive pulmonary disease is an irreversible inflammatory lung disease characterized by chronic obstruction of the lung parenchyma. The that alters normal breathing. It is further categorized into two conditions, namely emphysema and chronic bronchitis. So you can see a beautiful diagram of normal lung parenchyma. There is proper mucous membrane, there are bronchioles, and there is alveoli. But in the case of COPD patient, the you can see the inflammation, you can see the hyperinflation of the alveoli, also you can see the music production. So now let's relate the clinical manifestations with the diagram. All right, so Mrs. McDonald was, these are the clinical manifestations of Mrs. McDonald. We can see that her first clinical manifestation was dyspnea. So dyspnea is the main symptom in COPD patients that leads to deterioration in the quality of life, such as inability to perform activities of daily living. So dyspnea occurs due to effectiveness of respiratory muscle function that leads to dynamic lung hyperinflation and increased ventilation requirements. So it is a pretty technical thing, so it would be better if I explain it here. So each and every clinical manifestation would be easily correlated with this particular diagram. So the air movement during inspiration is seen. These are the bronchial walls. We can see the mucus plug. This is the alveoli. So the air goes down to the alveoli, and the problem occurs when we need to expire. So the alveoli has elastic walls and it expands. So there is air inside, but the problem is when we expire, there is less particular amount of air. So, and in the alveoli, there is proper gaseous exchange which takes place. So you can see the mucus production and the bronchial walls. Remember, it's an inflammatory disease, so the air gets trapped and there is an obstruction between. So there is an impairment in the alveoli function, resulting in very like a lot of problems. Person face a lot of problems. So this is why dyspnea occurs, because there is less amount of oxygen, and there is dynamic lung hyperinflation and increased ventilation requirements. So let's relate the second particular clinical manifestation. So the second clinical manifestation is respiratory rate of 32 breaths per minute. It can be termed as tachypnea. When the respiratory rate is more than the normal value, it is considered as tachypnea. Due to the airway construction caused by inflammation, you can see the airway obstruction caused by inflammation. The bronchial tubes get narrowed. This makes it difficult for the air to move in and out of the lungs, resulted in increased respiratory rate. Since there is a need for oxygen, our body craves for it, resulting in increased respiratory rate to fulfill the requirement. The next clinical manifestation is bluish tint to the lips and the mucous membranes. Since there is impaired gaseous exchange in the body, you can see over here, there is low oxygen level in the blood and the patient can be termed as hypoxic. Similar case is seen in the case of Mrs. McDonald. The bluish tint to her lips and mucous membrane is a result of altered gas exchange, as there is decreased amount of oxygen in our blood. The fourth clinical manifestation is the SpO2 level of Mrs. McDonald, is 86% on room air. So SpO2 is the oxygen level. We can say that there is no proper oxygen exchange. It is a condition which needs a proper monitoring and it cannot be neglected. So because there is no proper oxygen exchange, the gaseous exchange, this is the reason why mm, this is the reason why there is less amount of oxygen in her blood. Also, impaired alveoli functions also contribute towards the oxygen saturation. So, the productive cough with yellow phlegm is the fifth clinical manifestation. The mucous membrane is producing mucus as a defense and to trap foreign particles. The phlegm or the mucus can be of any color or the phlegm, but the phlegm here is yellow or purulent due to the exacerbation of the disease. The pulse rate is 130 beats per minute, and she can be termed as tachycardic. So there are many hemodynamic factors such as hypoxia and decreased stroke volume, along with inflammation, which contributes to this particular thing. So we can also for example, let's take hypoxia as a reference. Since there is less oxygen level in the blood, the heart will pump blood as a faster rate, resulting in increased pulse rate. Then comes the auscultation of the lungs. It identifies diminished breath sound because all the air is trapped inside the alveoli and there is obstruction in the normal passage pathway. There would be a diminished breath sounds. So the amount of air inspired is much more than the amount of air which is expired. All right, so the last clinical manifestation is the chest X-ray shows hyperinflated lung fields with patchy consolidation. So we already had a look at why there is hyperinflation, like there is bad elastic recoil of the alveolar walls. Also, we can see the patchy consolidation in X-ray because of the mucus formation. I hope it was a good presentation. So to sum up, it could be said that all the clinical manifestations are somehow correlated with each other, and all the clinical manifestations can be correlated with this particular diagram, and the things happening with this really helps us to understand COPD. Now I want to thank you all for listening. Thanks a lot. Thank you.